Friends, I bring you greetings from the city of Taj Mahal, and it is my privilege to participate in this prestigious program from Aga Khan University. And I'm especially thankful to Professor Hamad for this invitation. The subject which I have been asked to speak upon today is ECIRS, or Endoscopic Combined Intra-renal Surgery, one of the most happening hot topics in endourology today. This is my disclosure slide. I have no potential conflicts of interest to disclose. Now, we all know that urolithiasis is one of the commonest problems in the day-to-day practice of endourologists in Asia, and especially our countries in South Asia. And it has a very high incidence in many parts of our countries. Here is a list of the contemporary management options for stone disease, listed in order of their invasiveness. And the new kid on the block in this is ECIRS, which is essentially a combined approach, retrograde as well as antegrade, to the entire pelvic ileal system. Now, it is interesting to look at the evolution of the ECIRS. We all know that PCNL originally started in prone position, and the landmark year is 1976. For many years, prone position has been the standard approach. However, it is interesting to note that supine position was proposed by Valdivia within a decade of origin of PCNL. However, it did not become popular until the modification in Valdivia position, the Galdeco and the Barts, came in about 20 years later, which opened the way to this new approach, which is ECIRS. So this is the original, one of the original publications from Valdivia, where he demonstrated the benefits of supine approach over PCNL, prone PCNL. And in Valdivia's original approach, the patient was supine with a support under the flank with an elevation of about 30 degrees, which allowed access in supine position through the lateral side. However, as I said, it was this landmark publication from Professor Scafone and his wife, Cecilia, from Italy, which opened the way to ECIRS by using the modification in Valdivia position, what has been called the Galdeco modified supine position, or GMSV. So here, the patient is put in a lithotomy or a modified lithotomy position, allowing access to the kidney in supine position for percutaneous approach, as well as a retrograde access in the standard, like in the standard lithotomy position. So here, there is lateralization of the Valdivia supine position and a modified lithotomy where the contralateral leg is flexed, the ipsilateral leg is partially flexed, and the flank is raised to 25 or 30 degrees. And as you can see, This allows good access from below as well as from above to allow two surgeons to work simultaneously. Of course, you require two sets of everything here, including the cameras, endoscopes, and maybe even lasers, if you want two people to work together. There is also an option where one surgeon can toggle between two places, going from below and then coming from above, but that would be a little cumbersome, I presume. It is also important to understand that when you are doing ECIRS, you have a rather busy operation theater with two sets of surgeons, assistants, operating trolleys, in addition to the C-arm, the ultrasound, and the monitors of both endoscopes standing across the surgeon. This is the simplified view of the same thing. You can see surgeon 1 and surgeon 2 with two displays and the accessories. Now, when we are using the percutaneous approach to the kidney, we must understand that this allows the best efficiency in terms of stone-free rates, but it also carries a relatively higher morbidity. And over the years, we have been trying to reduce this morbidity by, first of all, finding the best way of accessing the pelvic ileal system without causing injury to the vasculature. And studies from Sampio at the turn of century showed us that this can be achieved by making a direct puncture to the papilla, to the calyx, and not to the infundibulum, because this is how you can avoid injuring the intra-renal vessels. And if one can keep in mind the avascular plane of the kidney, which is between the vascular territories of the anterior and posterior division of the renal artery, then one can access the posterior calyx directly without causing any injury. Now, access to the pelvic ileal system from above in ECIRS can be fluoroscopy guided or ultrasound guided. The access from below, of course, is straightforward. And for fluoroscopy guided access, our friend Guido Gusti has described it very nicely, that instead of turning the C-arm image intensifier 30 degrees towards the surgeon, you turn it cephalad or caudad, and by removing the parallax between the needle and the pelvic ileal system, one can easily make the right puncture without difficulty. So, first of all, you access the needle, move the needle towards the calyx, as you see in the first picture, and then you turn the C-arm cephalad, and if the needle is seen below the papilla, that means the puncture is too anterior. And if you see it above the papilla, that means the puncture is too posterior, and then you make the necessary correction. However, in our experience, in addition to fluoroscopy, what helps best, especially in supine position, is the ultrasound guided access. Now, to make the ultrasound guided access, one requires both fluoroscopic as well as ultrasound guided help. The benefits of ultrasound guidance are that it allows better assessment of the depth and plane by providing the third dimension. And easy identification of the dilated calyx, and if there is inadequate dilatation, one can use a retrograde injection of saline through the ureteric catheter to fill up. And of course, ultrasound guidance reduces the radiation exposure to the patient as well as to the surgeon. If you have a puncture guide, that is very, very beneficial, although freehand puncture can also be made with ultrasound guidance. And another additional help is the specially designed eco-tip needles, which have serrations, which show up beautifully on ultrasound. So you can access the lower tract using rigid or flexible ureteroscope, and you can make the percutaneous access with ultrasound guidance, as you can see in this picture on the left. And once the needle is in place, you can draw water by irrigating from below. And as you can see in this picture, the ultrasound allows you to watch the progress of the needle, making the puncture accurate with minimum radiation exposure. And by retrograde saline injection, you can also achieve good dilatation even in patients who did not have too much pelvic calyceal dilatation. And if you keep watching this tip of the needle, which because of being an eco-tip needle shows up very well on ultrasound, you can even see the guide wire passing down into the pelvic calyceal system. The puncture can be made, as I said, with puncture guide very accurately, but even a freehand puncture can be learned under ultrasound guidance. And you can, like the picture on the left, see the needle passing in. In undilated pelvic calyceal system, you can still make puncture with ultrasound guidance because you can see the shaft of the needle passing through the renal parenchyma most of the time, and you can confirm this puncture on fluoroscopy afterwards. So we published this some years ago, how ultrasound guided punctures help percutaneous access by reducing the operating time, radiation exposure, and improving accuracy. And since then, there have been many publications in the world, in international literature, confirming the benefits of ultrasound guided puncture as opposed to fluoroscopic guided. However, I must emphasize that one requires the fluoroscope, the C-arm image intensifier, in addition to ultrasound most of the time. Although there are some of our friends, especially from China, who do purely ultrasound guided procedure. The entire procedure is done with ultrasound guidance and fluoro is not used at all. Now, going further, with the conventional fluoro or ultrasound guided renal access, one does not see the running vessels in the renal parenchyma. With wideband color Doppler, one can see these vessels and one can try to avoid injury to the vessels, the vascular structures during the puncture. So if you make the puncture without the color Doppler, it could go into the papilla, but through the vasculature. And if you use the Doppler, you can make the puncture into the papilla in the least vascular way. And on top of that, if you can put a retrograde ureteroscope and observe the process of puncture and dilatation, it will be the perfect way of making a safe percutaneous access. One additional armamentarium which has helped reducing the morbidity of PCNL is the use of miniaturized instruments. And the same can be used for ECIRS. We have understood very well from multiple studies, including the CROW's global data, that the tract size has direct bearing on the amount of injury and bleeding in PCNL. So by reducing the tract size and using mini and ultra mini percutaneous approach, one can keep the morbidity really low. And this is more or less our standard of care nowadays. A mini ECIRS using a 15 or 16 French implant sheath. And you can use this for large impacted upper ureteric stones. You can use it for multiple renal stones. You can use it for patients who have renal as well as ureteric stones. And here is a case where the percutaneous access, the wire has been passed under endoscopic guidance. You can see that with the ureteroscope, you are watching the tract dilatation, passage of the nephroscope sheath, and the stone fragmentation. So, and then this is the percutaneous view. You can see the ureteroscope from above, and you can fragment the stone with mini PCNL and get all the fragments out, achieving complete clearance very quickly and very efficiently. And you can even see passage of the double J stent endoscopically, so keeping the radiation exposure to the minimum. This is another case with the flexible ureteroscope going up to the kidney and multiple calycial stones, which you will see are being brought down from the calyces into the pelvis to be retrieved by the nephroscope. So the flexible ureteroscope is passed under vision into the calyces containing stone. On the left, you see the flexi view, and on the right, you see the nephroscope view. And the stone is brought down into the pelvis, what is called passing the ball, and is retrieved through the nephroscope, either intact or if it's a large stone after fragmentation. And this keeps the number of tracts to the minimum, the bleeding to the minimum, and radiation exposure also is significantly reduced, and helps in achieving complete stone clearance in one procedure, single procedure. At the end, you have just a small 3 to 4 millimeter incision. The procedure is tubeless in the vast majority of cases, almost always just a double J stent. And at the end, just a small band-aid. And most of these patients go home the next day. The benefits of mini ECIRS are many. The patient position is supine, comfortable. Anesthetist has easy access to the airway. There is visual control of puncture and the tract dilatation. There is less need of multiple percutaneous tracts. Being supine, the dependent drainage helps in retrieval of stone fragments, and it's better ergonomics for the surgeon. And you have, of course, simultaneous access to the ureter in all parts of pelvic calyceal system. In addition, a major advantage is that the intra-renal pressure is kept low as opposed to the standard RARS, and the risk of urosepsis is minimum. There are a few limitations of mini ECIRS, that in supine position, kidney is a little more mobile, the percutaneous tract is a little longer, so renal puncture and tract dilatation and localization of the calyx under fluoroscopy requires a little bit of experience. There is a little restriction in the working surface area, and sometimes superior calyceal puncture can be challenging, although it is not difficult and can be done, and multi-tract PCNL can also be done in supine position. And sometimes the pelvic calyceal system remaining collapsed can interfere with good visualization. But all these limitations are only minor, and with experience one learns how to overcome these. So this is our recent publication on ECIRS in large impacted upper ureteric stone. It is just under publication. There are multiple publications. This is another publication showing benefit of ECIRS for simultaneous renal and ureteric stone access, and the results attest to the safety and efficacy of this procedure. Another study comparing ECIRS with mini PCNL, demonstrating benefits of ECIRS over mini PCNL alone, especially in complex nephrolithiasis. To summarize, mini ECIRS allows most of the patients to go home on an ambulatory or a daycare basis, less than 24 hours hospital stay. Because of low intra-renal pressure, the infection episodes are low, the stone-free rates are high, number of tracts is low, and the need for secondary procedures is minimized. And thus overall, this procedure, I believe, has great future. And I'm sure that in given time, more and more people are going to take to it. Thank you very much. I bring you greetings once again from the city of Taj Mahal. Thank you very much.